Welcome. Thank you all for joining us, the Leukodystrophy Newborn Screening Action Network, as we partner with the EveryLife Foundation for their wonderful, vast amount of knowledge about newborn screening in the United States. And that's what they're going to be talking about today. Like, what does the landscape of newborn screening look like? Tomorrow, they'll focus more on federal advocacy efforts. And so we're so happy that you all could join us today, and we hope that this is useful.
Thanks, Lisa. And my name is Melanie. I work very closely with Lisa on the Leukodystrophy Newborn Screening Action Network. My other hat is that I work for KRMLD. And I'm just going to talk about some Zoom practices real quick, even though we've all kind of been there, done that. If you can mute yourselves when you're not speaking, I think there will be time at the end for discussion where we welcome you to come off mute or come on video. Otherwise, you can submit questions, comments in the chat. We highly encourage participation. This is for you guys to learn anything and everything that you could possibly want to know. So please shoot us those questions. We want to know what you want to know. And we have Claire and Dylan here from EveryLife who are extremely knowledgeable about all things newborn screening. So we're lucky to have them here today, and I'm really looking forward to what they're going to teach us about the landscape of newborn screening. And just a reminder, so tomorrow is the second session, and that's at the same time. I think same Zoom link. You guys should have been emailed that confirmation with the Zoom link. And so with that, I will kick it off to Claire and Dylan.
Yeah, I can introduce myself really quick, and then if Dylan wants to as well before we start. My name is Claire Ellis. I'm the Newborn Screening and Diagnostics Policy Fellow at the EveryLife Foundation. So I work very closely with Dylan on newborn screening and diagnostics policy issues.
And my name is Dylan Simon. I'm the Director of Policy here at the EveryLife Foundation. And within what I work on is newborn screening and diagnostics, both at the federal and state level, as well as our advocacy work. And I will actually be giving tomorrow's presentation, but we'll be here to help answer any questions that may come up. With that, I'll pass it over to Claire, who can lead us through today's presentation.
Yes, let me share my screen. Oh, or do one of you want to pull up the PowerPoint?
I just changed the sharing settings, so you should be able to share, but I also can pull it up.
I can now, so we're good. Does it look normal?
We have the presenter view.
Okay, let me switch around here.
There we go.
Good now?
Yep.
Okay.
Looks good.
Great. So like I said, I'm Claire Ellis, and I work at the EveryLife Foundation as the Newborn Screening and Diagnostics Policy Fellow. And I'm going to be talking today kind of about newborn screening 101. And so really quick, I wanted to briefly talk about what the EveryLife Foundation does. So we are a nonprofit, nonpartisan organization that's dedicated to empowering the rare disease patient community to advocate for impactful science-driven legislation and policy that advances the equitable development of and access to life-saving diagnosis, treatment, and cures. And at the EveryLife Foundation, we don't speak for patients, but we really work to provide training, education, resources, and opportunities to make their voices heard. And by activating the patient advocate, we really believe that we can change policy and save lives. Okay, so I'm going to jump right into it on what is newborn screening, or NBS, as you'll see it referred to throughout this presentation. And newborn screening is a public health program that tests every newborn for genetic and metabolic, hormonal, and functional conditions that are not otherwise apparent at birth. Newborn screening is a public health program that tests every newborn born in the United States. And these tests are typically performed within the first 24 to 48 hours of a baby's life. They include a blood test, a hearing test, and a pulse oximetry test. And if a baby receives a positive screen, confirmatory testing must be performed before a diagnosis can be made. It is important to note that newborn screening itself is not a diagnostic test. It is just a screening test. So for newborn screening, if a child screens positive, they will have to undergo additional testing before a diagnosis can be made. Typically, a child, if they screen positive in their first newborn screening, will undergo a second-tier test before they would undergo then the confirmatory testing to determine if they have this condition. A newborn screening is a state program, so every state decides their own newborn screening program, which means that states, or what conditions states screen for varies, but every state does screen for at least 31 conditions. And so here's some facts about why newborn screening matters. Like I said, it screens every newborn born in the United States for certain conditions. This reaches about 4 million newborns every year. And of those 4 million newborns, about 1 in 300 has a condition that can be detected through newborn screening. And again, these tests test every newborn for genetic, metabolic, hormonal, and functional conditions that may not otherwise be apparent at birth. And really, at the heart of it, newborn screening seeks to facilitate timely delivery of life-saving treatments and other therapies to improve the quality of life. So how is newborn screening performed? Like I said, newborn screening is performed via a blood test, a hearing test, and a pulse oximetry test. The majority of conditions that newborns are screened for, they're screened for via the blood test. And so the blood test, like you can see in this picture here, the baby receives the heel prick within the first 48 hours of birth, and then 5 drops of blood are collected on a piece of parchment paper. And then these dried blood spots are sent off to a public health lab to be tested for certain conditions. And I wanted to give an example of how Krabbe disease is tested for. So with Krabbe disease, I'm so sorry, there's a fly. For Krabbe disease, these dried blood spots are tested for functioning levels of the Galc enzyme. And if the dried blood spot is found to be outside of an expected range, a second tier testing is ordered. And for Krabbe disease, that second tier test measures the concentration of psychosine in the blood. And then if the concentration is found to be too high, the baby will undergo confirmatory testing. And that confirmatory testing is where a diagnosis is made. So newborn screening, like I said, is primarily a state program, but that doesn't mean the federal government is not involved at all. The federal government seeks to support newborn screening through a variety of programs, as well as through the Advisory Committee on Heritable Disorders in Newborns and Children, which is really a mouthful, but it's the ACHDNC. And the ACHDNC seeks to advise the Secretary of HHS on policies and priorities that will help reduce the morbidity and mortality in newborns who have or are at risk for heritable disorders. And what the ACHDNC is really most known for is making recommendations to the Federal Recommended Uniform Screening Panel, which I will talk about here more in just a second. But the ACHDNC also considers ways to aid states in their capacity to screen for condition, and also seeks to support the HRSA grant decision-making process when it comes to supporting state newborn screening programs. So the RUSP, the Recommended Uniform Screening Panel, is the list of disorders that the Secretary of HHS recommends states screen for as part of their state newborn screening program. Currently, the RUSP includes 35 core conditions that the Secretary of HHS recommends states screen for, but there should hopefully be 2 new conditions added by the end of the year. The ACHDNC meets quarterly, and they will make recommendations on what conditions they think should be added to the RUSP, and the Secretary of HHS will then consider their recommendation before making the ultimate decision on whether or not they want to include a condition on the RUSP. And the ACHDNC met in February and May so far this year. And in February, they recommended that NPS 2 be added to the RUSP. And then in May, they recommended that GAMP deficiency be added to the RUSP. So the Secretary of HHS will now have 6 months to decide if they want to recommend both of those, or they want to include both of those conditions on the RUSP. The Secretary of HHS has never not included those conditions recommended to them. So we expect those to be added, and hopefully that number will grow to then 37 core conditions by the end of the year. So here I wanted to talk about, I wanted to highlight kind of the process of how a condition gets added to the RUSP and how that plays into state implementation. So every condition that's added to the RUSP really follows this kind of arrow here. At the beginning, you can see evidence development, and that's really kind of one of the most important things when it comes to adding a condition to the RUSP. That's when an organization begins to gather evidence for the condition they want to be added for the RUSP. So say an organization wants to recommend Krabbe or MLD or any or ALD, which has already been added to the RUSP, but when they wanted to add these conditions, they had to begin by developing evidence. And that includes things like natural history studies, baby sibling studies. They need to run a pilot program to ensure that states are able to screen for these conditions and to ensure that the screening method does work to catch babies. There also has to be a treatment that exists. So these organizations really will have to spend quite a bit of time to gather all of this evidence before they can nominate the condition to the RUSP. And once these organizations have all of this information gathered, all of this data and evidence gathered, they will submit a nomination package to the advisory committee. The advisory committee will then receive the package and decide on whether or not they want to accept the package. If the advisory committee opts not to accept the package, they will send it back, normally with a letter kind of explaining why they did not accept the package, so that organizations can then gather the additional evidence they need so that in the future they can resubmit their condition for the RUSP nomination review process. If the advisory committee does opt to accept the package, they will then move it to the evidence review committee, and the evidence review committee will review the package before compiling a summary and presenting that to the advisory committee. The advisory committee will then review that summary and decide whether or not they want to move the condition onto the final evidence review process. If the committee opts to move the condition onto the final evidence review process, the evidence review group will then compile a report, compile a summary for the committee, and submit that to the committee. The committee will then review that final report before ultimately deciding if they want to recommend a condition to the RUSP. If the committee opts to recommend the condition to the RUSP, it goes to the Secretary of HHS. Secretary of HHS can then add it to the RUSP if they like. If it does not, if they don't recommend it to the RUSP, they send it back to the organization, again with some notes with some comments on why they don't want to recommend the condition to the RUSP, so that these organizations can then again build more evidence, find what they're missing, and add it to the RUSP, or add it, to their nomination package to submit to the RUSP. That's a long process. It takes quite a bit of time, and the committee does, they will not recommend conditions. They've done it before. They actually, Krabbe is undergoing this process right now. Krabbe is in the final evidence review process. So Krabbe has previously submitted their condition to the RUSP, or to the advisory committee. The committee opted not to recommend the condition to the RUSP, and the organization that submit the Krabbe package work to mine all the information, develop new evidence, so they could resubmit the condition. And the condition is now in the final evidence review process. So hopefully sometime next year, the committee will review the final evidence review, the final evidence review groups report on Krabbe before deciding if they want to add the condition to the advisory committee, or to the, to the RUSP. Another condition that has been recommended but not added before is GAMP deficiency. So like I said, it was just added, or was just recommended by the advisory committee to be added to the RUSP last month, but previously the advisory committee had not recommended RUSP, or had not recommended, there's so many acronyms in this, and not recommended GAMP deficiency to be added. And so once the condition is added to the RUSP, that's where state implementation begins. But before I get into state implementation, I wanted to very briefly go over kind of the 6 considerations that the advisory committee considers before they decide whether or not they want to recommend a condition. So the first is that screening is needed to identify all babies who need treatment. So they want to ensure that screening is what is needed to identify. A lot of these conditions are hard to identify because they're obviously rare disorders. They want to ensure that if they are screened for as part of newborn screening, it's because these conditions cannot really otherwise be identified until symptoms have started. The second is that there's significant risk of illness, disability, or death if babies are not treated promptly. They want to ensure, again, that newborn screening is the right time to screen for these babies, and they want to ensure that if these babies are caught via newborn screening, that this screening, that they're then able to access treatment right away, and that this treatment early on is really kind of going to make a difference for the baby. The third is that effective treatment is available. The advisory committee will not add a condition if there's no treatment available. They are not interested in, do not believe adding a condition with no effective treatment is right. They are only going to consider conditions that have an effective treatment available. The fourth is that the treatment is more beneficial in the newborn period than later. Again, they want to ensure that if they're screening newborns for this condition, then in the early stages, that these conditions, or that this treatment is really effective. A lot of the conditions that are on the RUSP, the conditions that newborns are screened for, are conditions that, when treatment begins, a lot of times treatment cannot begin until they are symptomatic, because that's when you can identify they have the disorder. And if you're beginning treatment and they're symptomatic, it's almost too late. A lot of these conditions, the treatment it can only stop or slow the progression of this disorder, but it cannot undo a lot of the progression that has already been done. So you want to ensure that if these conditions are added to the newborn screening panel, or screened for, that the treatment can begin earlier and kind of slow the progression of the disease before the baby is symptomatic and before it can really have a detrimental effect. The fifth is that resources and access to treatment and counseling are widely available. Again, they want to ensure that there's a treatment available and that it is not impossible to access. They want to ensure that families can access this treatment. And the sixth is that the benefits to babies and to society outweigh the risks and burden of screening and treatment. They want to ensure that there are not too many false positives. They want to ensure that these false positives don't outweigh the benefits to the baby. And they want to ensure, again, the treatment is effective and important that it be given during the newborn period. Whoop. So like I said, newborn screening is a state kind of run program. Each state has their own newborn screening program, and each state can decide what they want to screen a newborn for, what conditions they screen that newborn for. If they have an advisory committee, how much they charge the screening fee for, a whole host of things. So this is an example of what California's newborn screening program looks like. And if you're interested in seeing what your state newborn screening program looks like, we actually have on our website under our Action Center a map that you can kind of hover over and see how many conditions your state screens for, see how it compares to other states, and you can click on to find more in-depth information about each state. But this is really just to highlight that each state runs its own newborn screening program and that each state makes its own decision when it comes to newborn screening. So depending on the state you're in, if you're in New York, your baby may be screened for 35 conditions, but if you're in New Jersey, your baby may be screened for 34 conditions. And what those 35 and 34 conditions are can depend on the state too. So it's really kind of a mess, I guess, of newborn screening. Another thing is you could see in the previous slide, it was, does your state have a newborn screening advisory committee? And these are similar to the federal advisory committee, but each state often has their own. There's 48, newborn screening advisory committees. So 2 states currently don't have them. We're almost all 50, but most states have an advisory committee. And basically it's a committee that advises their state on newborn screening programs. So it's similar to the federal run, but it's really at a state level. And these advisory committees meet anywhere from quarterly to annually, depending on the state. And the members are typically appointed and can be medical experts, laboratory experts, organization representatives, and patient advocates. And depending on the state, the committee may provide advice relating to planning, evaluation, modification, and management of statewide newborn screening and follow-up care. And these committees can recommend what conditions are screened for, but ultimately the final decision typically lies with the Department of Health. So again, it mirrors pretty similarly the federal one, where the state will they will consider a condition, review the evidence before they make a recommendation, and then the Department of Health will typically decide if they want to add a condition to be screened for. So here I wanted to just kind of highlight ALD, Krabbe versus MLD. ALD is currently on the RUSP. Krabbe is currently pursuing RUSP inclusion, and MLD is kind of at the very beginning, the evidence kind of gathering phase. So for ALD, it was added to the RUSP in February of 2016, and is currently screened for in 28 states. But 4 of the states that do not currently screen for ALD passed RUSP alignment legislation in the past 2 years. And I'll talk more about RUSP alignment legislation here in just a minute or two. But basically that should help kind of speed along for those 4 states. So hopefully we're at 32 states in the next 2 years or so. Krabbe disease is currently pursuing RUSP inclusion. So like I said, it had previously pursued RUSP inclusion in 2009, but the ACHDNC ultimately did not recommend the condition for inclusion on the RUSP. And it is now currently undergoing the nomination process again. It's about halfway through, and sometime next year, the ACHDNC will consider whether or not they want to recommend it to the RUSP. Despite that, it is screened for in 10 states so far. And then MLD, like I said, is really at the beginning of their kind of RUSP nomination process. It's currently screened for in New York as part of the Screen Plus pilot program. Pilot programs are really important when it comes to gathering your data and gathering your evidence to submit a RUSP nomination package. It's important to highlight to the advisory committee that your condition can be screened for, and also helps answer a lot of the questions they may have about false positives, false negatives, and kind of the consequences of screening. So like I said in my previous slide, I was going to talk about RUSP alignment legislation. And RUSP alignment legislation is legislation that the EveryLife Foundation that we work on in conjunction with patient advocates to really speed how many conditions are screened for, to really make sure that states are screening for all of the RUSP conditions as soon as possible. So obviously the RUSP process is very long. It's very intensive, very evidence-based. So it's a long process, and it's not taken lightly. Like I said, the ACHDNC has opted not to include conditions before. So really it's going through a rigorous process. And we feel that if it goes through that rigorous process, states should be able to capitalize on that too. And we're finding that after these conditions are recommended to the RUSP, it still takes on average 5 to 6 years for a condition to be screened for in the states. We think that's just too long. So through RUSP alignment legislation, we're really trying to get these conditions screened for in a much more timely manner. We're really trying to speed how long it takes for these conditions to be added to the state panels. And our RUSP alignment legislation does 3 things. The first is it requires states to screen for any disorder recommended by the federal RUSP. So it requires states to be aligned. So like I said, we're hoping that these 4 states that we've passed RUSP alignment legislation in that do not currently screen for ALD will screen for ALD within the next 2 or 3 years so that they are aligned with the federal RUSP. And the second part, kind of one of the most important parts of RUSP alignment, is it implements a timeline for when the state needs to begin screening for new RUSP disorder. So we don't think it's enough to just require states to screen for conditions on the RUSP, because a lot of times they'll kind of drag their feet. Like I said, it takes 5 to 6 years. So we want to ensure that if states are agreeing to screen for conditions on the RUSP, they're doing so in a timely manner. And so most states typically their timeline is about 2 to 3 years before they will begin screening for a new condition. And so that's why we're hoping ALD will be on these screen for in these states in about 2 to 3 years. And then the third is ensuring that funding is available moving forward to facilitate addition of new screen/conditions. So we want to ensure that if we're requiring states to screen for all the RUSP conditions, they're able to do so. They're able to fund their newborn screening program. When states begin screening for new conditions, they may need more than just to screen for the new condition. They may need additional staff. They may need additional equipment. Some states even need additional space to house equipment. So we want to ensure that these states really have the funding that they need. And because the RUSP is continuing to grow, because we're hoping that the RUSP will have 37 conditions, hopefully by the end of the year, we want to ensure that states are ready to add these conditions and that they're able to continue functioning at the levels that they are now. So this is just kind of a map of all of the states that we've passed RUSP alignment legislation in. As you can see in the dark blue, we previously passed legislation in California and Florida. We've passed legislation in Arizona, Georgia, North Carolina, and Ohio. And then in this year, we passed legislation in Mississippi, Iowa, and Maryland. It's important to note, it's not on this map, I'll have to update it, that Pennsylvania is also considered RUSP aligned. And it's not legislation that we worked on, it's legislation, or it's regulation I know Lisa was very involved in, but Pennsylvania is also considered RUSP aligned. I'll have to update the map after this. But basically all of these states will have to begin screening for RUSP conditions within a certain period of time. Each state is different on how much time. So for example, we passed legislation in Mississippi this year and they'll have 3 years to begin screening for a condition. But in Iowa, they'll have 2 years. And kind of a difference too with Iowa and Mississippi and some of the other states is Mississippi, it's an automatic inclusion. So in 3 years, they'll just have to begin screening for a condition added to the RUSP. But in Iowa, our legislation really works to bring in the advisory committee. So in Iowa, the advisory committee has a year to decide if they want to add a condition. So it really just begins the timeline of when the advisory committee must begin considering a condition. So in Iowa, the advisory committee will have a year to decide if they want to add the condition. If they opt to add the condition, then the public health lab will have a year to begin screening. So depending on the state it is in, the RUSP alignment legislation is a little different because not all states are obviously the same, and we want to ensure that it's successful in each state that it's in. But it's really just, again, seeking to add these conditions within a certain period of time. And this is Dylan and I's contact information. If you have any questions, I have an additional slide. If I'm assuming there's probably some questions out there. I see that there's a couple in the chat, but also at the end of this, if we have any questions, if we don't have any questions, I can also talk about some more federal newborn screening programs. But let me look here at the chat now, see what questions there are. Yes, Iowa is a great addition. Iowa, we actually went and pursued RUSP alignment legislation because it is a hub state. So it screens for North Dakota, South Dakota, and Alaska. And so we were really excited to pass legislation there. So in each state, the funding can be different. So a lot of states receive funding from the federal level or from the federal government, as well as kind of state funding. So each state, some states do like a fee. So in Iowa, for example, we passed legislation. And in Iowa, they can opt to raise the fee. The public health lab can raise the fee as they see fit so that they can screen for new conditions. Some states have a newborn screening fund where money just comes out of, and some also can request additional funding through a budget request when the state government is considering a new budget so that they can ensure they have enough funding to screen for. But each state is different. And if you go to our website, if you look at the map, you can kind of see how your state funds because each state does.
And just want to hop in here real quick. I'm dropping something in the chat around funding. And I just want to make sure I'm getting these numbers right, just because they come from APHL, which houses a lot of this and talks about how 85% of newborn screening funding comes from those newborn screening fees. And so those fees will vary by state. And the reason they vary by state is because, not surprisingly, the cost to run a full newborn screening program in California is going to be different than Rhode Island. They're just bigger states. It's going to cost a little more money in those states. And so that's where a vast majority of the funding comes from. And so when talking about funding, I think it's always, first and foremost, you definitely want to look at those fees and see what they are, how easy it is to raise them or not to raise them, and so on and so forth.
Yeah. And then to Melanie's question, can you add non-RUSP conditions to states that have RUSP alignment laws? Yes. So when we go in with RUSP alignment, we really are seeking to make RUSP alignment the floor. So we really just want to ensure that states are screening for conditions that are on the RUSP kind of as the bare minimum. We want to ensure that if these conditions have gone through this rigorous evidence review process to be added to the RUSP by the ACHD&C, that states are then taking advantage of it, but it doesn't prohibit states from adding other conditions. Many states screen for more than the RUSP conditions that are available, but we just, again, want to ensure that states at the minimum are screening for them. Because like I said, I believe every state that we went into this year did not screen for ALD. So we wanted to ensure that Maryland, Mississippi, and Iowa began screening for ALD, and then hopefully begin screening for MPS 2 and GAMP deficiency if the ACHD&C does opt to add those to the RUSP by the end of the year. Right. So if just because there is the recommended, I'm assuming you're asking, are you asking about RUSP alignment or just the RUSP in general? Katie. Okay. Yeah. So the RUSP is just recommended. So it's the recommended uniform screening panel, which means that states are not required to screen for it. So it goes through this rigorous federal process, and then states are encouraged to follow the RUSP, but they're not actually required to. And so we're really just through RUSP alignment legislation, we're really kind of trying to make sure that states are looking at this and that they're following it. Again, some states, they can still choose not to recommend a condition after their advisory committee has reviewed it, while some states, have to do it within a certain period of time, but it is recommended, so it is not required at the state level.
And I think it's also worth noting, and we'll talk a little bit more about this tomorrow in terms of how to advocate for these issues, but quite often when conditions aren't added to a state program, it's not because they don't trust the RUSP process or don't trust the advisory committee. It's just a question of how easy or hard is it for them to add that condition to their state. So it's more of they understand that it's ready and want to add it, but what is the cost to adding, doing initial quality control to ensure that it's ready to be added. All of this should occur faster than it currently does. As I said, it takes on average 5 to 6 years to add a condition to a state panel after it's been added to the RUSP. We believe that should be much faster, which is why we have that 2 to 3 year timeline for RUSP legislation. But I think this is important to note in terms of like when states aren't adding it, especially when it comes to the RUSP, it's not necessarily of oh, we don't believe in what the RUSP is saying. It's more of, are we in a place to add this condition in our own state?
Yeah, and just to kind of build on that, when we went to Iowa, they hadn't been able to raise the screening fee since 2011. So I don't think that it was they didn't want to add the condition. It was that they physically could not afford to add the condition. And so in Iowa, and kind of answering Rob's question, do you reach out to the newborn screening advisory boards in each state to get their feedback? In Iowa, we worked with their newborn screening advisory board to kind of figure out what the best process was. And we're hoping now through the legislation, prior to the legislation, they had to go through regulatory process to request a fee raise through the Department of Health. And now with the legislation, the public health lab will be able to raise the fee as they see fit. So we're hoping that if the public health lab is able to raise this fee and kind of don't have to go through all of the regulation, they'll be able to raise it sooner and add new conditions. So sometimes it's just, they're slow. It's not that they don't want to screen for a condition, it's the funding is not there and it's really hard to get new funding. It's a shocker, states don't want to give people more money. Everyone's always asking for more money. So it can be hard, kind of the fee can often be a problem and kind of prevent states from adding new conditions, even though they do want to screen for them.
And just to build off Lisa's point to Bob's question, in terms of the advisory boards, we also encourage it. I think we'll go into a lot more depth on this tomorrow, so I kind of want to put a pin in that conversation. But I think also, just again, to build off Claire's point a second time, while they're always willing, I think it's also helpful to realize that like sometimes they do need to get pushed a little bit. That's why RUSP alignment legislation exists. Quite often we'll have these conversations, and you just 80%, 85% of the conversation, you'll appreciate where they're coming from, agree with them in their hurdles, and that lasts a little bit, and it just feels like they're dragging their feet a little bit. So I think there's always kind of that balance of when working with advisory committees or legislators or public health departments to recognize that they want to do this, but also recognize that they're taking this long to begin with. So there's something standing in their way, and that can be the role of patient advocates to kind of help push, pull, remove the barriers, just kind of working to get the public health department to move a little faster. The mandatory aspect is definitely always will come up at times, but I think when discussing mandatory, that's why you see such a high bar to be added to the RUSP itself. That's why there is a full conversation within the newborn screening community at the moment in terms of implementing whole genome sequencing as the initial newborn screen, because there are some within who say, well, if we can provide the diagnosis, we should just give the diagnosis as early as possible, which is a point of view that many within the newborn screening community support. But there are some on the advisory committee, as well as other members within the community, who state that if you're going to make it mandatory, that you need to make sure that there's a treatment on the back end. And so that's when mandatory, because mandatory is involved, you do often, that's why you tend to see that higher bar in terms of what is required to be added to these panels.
And also to kind of to build on Dylan, some of the states that pass RUSP alignment are like Iowa, where it's not mandatory. The final decision still lies with the state. That's how it is in Florida. I believe that's how it is in Georgia. Correct, Dylan?
Yep.
So sometimes the final decision will still lie with the advisory committee. So each state is kind of different. And it kind of depends when we go in. We work again closely with the advisory committee, closely with the patient advocates in the community to determine what's best in the state. So some of these states were just implementing a timeline so that the advisory committee is required to vote. And they are not required to vote yes. Sometimes the advisory committee can vote no. And in the some of the language we have, then they're required to consider it again in a year. Like if they voted no, we would just like them to consider it again. So they're not all required to add it. It's not mandatory necessarily, but we just want to make sure that we're starting the process and that the advisory committee in each state is considering the condition.
And just like Claire reads the question that just came in, I'll put a final point on that. For instance, in Florida, that has that type of legislation in when SMA was added and it came up for a vote, initially it was voted down. It was not approved. And so the state still had that right. 6 months later, a group of patient advocates attended the next Florida Advisory Committee meeting, spoke in support of adding the conditions, and they added the condition to the Florida panel. And so in terms of that mandatory, when talking about this, it's always, it does provide the opportunity to say no, and states have. And we're actually working on some one-page and some advocacy materials right now in terms of how to approach adding a condition in your state, whether if you're in a RUSP-aligned state. And so we'll definitely have some more on that in the coming months. And Claire, I'll pass it back to you.
Yeah, really quick, just building off of Lisa's comment. Yeah, we're really, I would say yes, we're really trying to empower the newborn screening boards to kind of have more control, the labs to have more control, especially in Iowa. Both the newborn screening board now and the labs have more control because in some of the states too, the advisory committee didn't necessarily have, in Iowa specifically, their power wasn't necessarily delineated in law. And so through the RUSP alignment legislation, we were able to kind of empower them and give them a little bit more power that their conditions, they had a certain period of time to review it. And then the Department of Health chair has to obviously look at their recommendation. And then obviously we gave more power to the labs by allowing them to raise the fee so that if they are wanting to add a condition or if the advisory committee has asked them to add a condition, they're going to be able to afford to add it. And then on Mike's question, when we say states couldn't afford it, have states moved around funding to align to the RUSP, whereas those who couldn't afford it made the decision to not reprioritize the funding? So in states that we've pursued RUSP alignment legislation, again, we've worked closely with the advisory boards, we've worked with the legislatures, we've also worked with the Department of Health to kind of determine funding, and each state is funded differently. Each state requires or kind of has laws or regulations around their funding. So each state is different that we go into, and we work with these advisory committees, with these stakeholders to determine what the best way to increase funding is. Some states we go into, they're already able to kind of raise the fee as they see fit. Specifically in Maryland this year, we looked and they were already able to kind of raise the fee as they needed to increase funding. So some states, they just need help. In some states, you know, they're able to increase the funding, but that may not necessarily be what is stopping that state from screening for a new condition.
So I think I'll get into, Mary, your question a little bit tomorrow in terms of the role of patient advocates versus large advocacy groups. But I think in general, everybody's needed. I think each plays their role. I will say the larger groups probably have more role on the federal side, but at the same time, we are a federal-based organization. Claire and I are both based in DC, but we still are active at the state levels. But when we're active at the state level, it's in a partnership with individual patient advocates in those states. And so I think, and again, I'll talk a lot about this tomorrow in terms of how to build that coalition, because that's going to be such an important part of not just newborn screening, but advocacy in general, is having that coalition and recognizing how everyone can work together to move forward.
And for Virginia, I'm looking, I believe they screen for, I want to say they screen for all 35 conditions, all 35 RUSP conditions, but let me double check here.
They do currently screen for all 35. I will say, I know they, and Lisa, I think, can actually speak to this a little more in terms of what is going on in Virginia, but I believe they added Krabbe by law 2 years ago or a year ago, but they have had, implementation has been a issue. So I think, and before I let Lisa kind of fill in the gaps, I think going back to the previous question in terms of helping to support the labs and the public health departments, I think a big part of this is you have seen quite often in a lot of states, sometimes state assemblies and state legislators don't communicate as well as we would hope with their state public health labs. And that's a lot of what we're working on, is trying to ensure the fact that there are some states where that conversation didn't happen, and a condition was either added when the lab wasn't ready, or the assembly legislator didn't properly communicate to the lab, like, this is coming, you need to start getting yourself ready. And so that's kind of a big part of the legislation, is to do that, as well as to make sure that patient advocates can kind of have that voice. But for more Virginia specific, Lisa, I think you probably have the most up to date.
So yeah, with Krabbe in Virginia, they did consider it in 2020, and then they proceeded to publish an article earlier this year about why they chose not to screen for it. But what we noted is that it wasn't necessarily that they were against screening for Krabbe. They believe that their system cannot handle it. They also were using outdated information about the treatments and about even the screening for Krabbe, and they kept claiming there was false positives and things like that. So we have been working behind the scenes. We also published a response to their letter, but we are trying to help them in any way that we can to make sure that the program is stronger so that they can add things like Krabbe and MLD without issue.
Does anybody have any additional questions, either about how conditions add to the RUSP or the newborn screening process itself? Happy to answer any questions. No.
Hi, yes, I have a question. This is Katie. I figured I would just ask it verbally instead of typing. Where are you guys working with an organization called Hunter's Hope? We recently became aware of them, and I know they do a lot of advocacy efforts. Do you guys have any affiliation with them, and to further efforts for newborn screening for Krabbe in specific?
I can hop in here. So I would say, in terms of official affiliation, at least at the EveryLife Foundation, they're a member of our Community Congress Working Group, which is a strategic advisory council. And we have a working group that's specific to newborn screening, and they're a member of that. And they're, I'm not sure her essential title, but I'm pretty sure president, Anna Grantham, who we work a lot with as well. And I know Lisa also does some work with them, so I'll pass it over to her.
Yeah, we at the Leukodystrophy Newborn Screening Action Network are we're a coalition for all of the different advocacy groups. Sorry. So yeah, we do work across leukodystrophies and lysosomal storage disorders. So we're very, very familiar with Hunter's Hope, and we do work well with them.
Great, thank you so much.
Yeah, and on Katie's kind of comment in the chat box, we'll talk about it a little bit more, but it's kind of parents can be advocates, patient advocates can be involved in their advisory committee. Each state advisory committee is different, but there's also other ways if you're not able necessarily to join the advisory committee that you can be active. Dylan will talk about it more, but there's always opportunities to kind of attend those hearings or offer public comments as well too, just to be active and kind of monitor what your state advisory committee is doing.
So Mayor, to that point, I think when creating those committees, they try to ensure the fact that they have people who are experienced in the broader newborn screening space, because each disease is unique and each experience of those diseases is unique. So you need to find some overarching themes, because you're not going to be able to create unique committees for each condition that is seeking to be added to the newborn screening panel. But that gets to the place where that's the role of parent advocates and patient advocates who speak at those advisory council meetings. I can speak to at least at the federal level, when the RUSP nomination package is officially reviewed by the advisory committee. There are two ways that happens. So currently there are 7 members on the advisory committee. None of them, to my understanding, are disease specific in their education or their expertise. But they have that overarching newborn screening experience. However, when a condition is reviewed, there's a technical expert panel, which is made up of parent advocates as well as researchers and clinicians who are more specific to that. So for instance, for MPS II, you're having doctors who treat MPS II patients, you have MPS II advocates, you have MPS II researchers. In addition, there's a public comment section which allows for these advocates to provide testimony ahead of the review. So it gives the opportunity to hear from the disease specific. But when speaking to the standing committee itself, quite often they're going to ask those committee members to be able to look at it from a broader point of view. Does anybody have any additional questions? I know Claire has an additional slide for us. If there are not, but happy to continue answering your questions.
I have another question. This is Katie again. Could you guys speak to, or could somebody speak to some of the slight differences in the newborn screening for Krabbe in specific? I could be mistaken, but my understanding is that some states, they have some slight nuances in how they actually screen for it. I thought I read recently that I think Kentucky is one state that does screen for Krabbe. And I think they measure the cytosine levels, whereas some other states that still do screen for Krabbe don't. And so I don't know if one of you guys could speak to maybe some of the slight differences. I guess what I'm saying is my understanding that some states differ in sort of their escalation levels or how they, want to do further screening if a child's, levels come back as abnormal, and how they continue to screen for it, or different chemicals or components. I don't know if I'm making sense, but could one of you speak to that?
Yes. So there are several states out of the 10 that their law specifically prevents them from doing the second tier testing. And that's something that we're also trying to work on. Like Ohio is not allowed to test for cytosine. New Jersey does not. I actually have Krabbe specific information that we can maybe send out as a follow-up email, but I'm just looking at my spreadsheet here. So there are at least 3 states I know of that don't do the second tier testing. And because of that, they've had a large amount of false positives. I mean, large amounts. But, we're still kind of learning, and New York State was the first one. And so they've had a large amount of false positives. but they're the ones who realized we need to be testing for psychosine as well. So Pennsylvania, for example, my pride and joy, because this is the state I live in and was responsible for. We have found 4 babies. We found 4 babies in the first 7 months. We've had 0 false positives because we do the psychosine testing. Ohio has not, that's not been the case. So those states sometimes, because of how the legislation, like some of these were, put in place by legislative mandate, and the mandate was not written properly. So now their hands are tied. So Ohio is actively working, and we are working with Ohio to try to resolve some of those issues so that we can make it better. I hope that answers your question.
Yeah, yes, it does. Thank you so much.
Well, I can go on to my final slide then, if and feel free to continue to add questions in the chat if they come up. It's just real brief. It is, let me see here. It's just kind of a list of additional newborn screening programs that the federal government supports. So like I said, the ACHDNC is kind of the most notorious one, and it really has a big impact on newborn screening, but the federal government does seek to support newborn screening in other ways. One way is that the Health Resources and Services Administration, or HRSA, they offer grants to states to expand and improve their screening programs, to educate parents and healthcare providers and improve follow-up care for infants with a detected condition. This is really where the federal government seeks to kind of support states as they screen for new conditions. The CDC also helps to maintain laboratory quality and surveillance through the NSQAP, which is the Newborn Screening Quality Assurance Program, and they help to make sure that the lab technology is working correctly, that they are quality assurance are able to check and use previously dried blood spots to assure that these tests are still working and they're still screening children positive for conditions that they have or that are able to be weeded out in second-tier testing. And then finally, the Hunter Kelly Newborn Screening Research Program at the Eunice Kennedy Shriver National Institute of Child Health and Human Development, which is also a mouthful, works to coordinate research in newborn screening and help support newborn screening through different research opportunities. Does anyone have any questions about these programs or any other questions about anything we discussed at all today? Recommended uniform screening panel, the ACHDNC, any other questions?
I do want to highlight one thing about NIH. The Hunter Kelly Newborn Screening Research Program is a fantastic program that helps coordinate newborn screening research, but it's not the only avenue that newborn screening research does occur. You'll see it occur across the NIH at some other institutes, but those will be more disease-specific areas. And so for instance, there is a National Lung, Blood, and Heart Institute. I think I may have mixed that order up, but in general, they're all together. And so if there are any diseases that specifically implement those areas, you'll get disease-specific research coming out of there, whereas the Hunter Kelly program is looking more at a broader aspect in terms of how do we look at newborn screening as a whole, as well as you'll see some pilot studies also get funded out of this effort as well. One of the biggest pilot studies is known as Screen Plus, which I believe MLD is a part of, and they receive a fair amount of their funding through from the NIH. One other thing I just wanted to add on top of this is you can see here within these federal programs, they're split into a few different areas, and both these are fantastic programs, but I think it's also important to highlight how they relate to the states. And the fact that states don't have necessarily these, it doesn't break out this way. So you'll have your state labs and you'll have your newborn screening follow-up service, but it's all kind of lumped together. And so that's kind of one of the main areas where the federal government kind of play a role within the state, is to provide some of that more unique expertise, the ability to take the time to develop these educational resources from HRSA, or to take the time to learn how to validate the tests. Quite often when a condition is added to the RUSP, the CDC already knows or is in the process of learning how to best run these can best run the screening methods so that when states want to add, they can reach out to the CDC and say, what should we be doing? What should we be setting our machines at? What should we be measuring for? How do we best screen for this? And so I think it's always kind of great to think of the federal government as the resource for the states, and the states are the ones who are the ones on the ground getting the work done. Claire, any final points?
I don't think so. Just that we'll be talking more kind of about advocacy and kind of state advisory committees tomorrow. And if you think of any questions tonight from this presentation, you're welcome to ask them tomorrow, and Dylan and I can answer them. And go back to, if you randomly think of anything else too, you're welcome to reach out to Dylan or I with your questions too, and we can try to help answer them.
And I'll just say thank you, Claire and Dylan. That was really informative. And thank you everyone who participated. You guys had great questions. And yeah, we'll be here same time tomorrow with more information. And I hope that you guys found today helpful. So come back tomorrow for more, and happy to answer any further questions as well.